Hi, everyone. Thank you for joining us. This is Remember That Patient, Confronting the Shame Response to Improve Education and Wellbeing. I'm Laura Welsh. I'm joined on screen by Avery Clark and Carrie McCabe, and we're all from Boston Medical Center. And just at the top of this talk, we also want to acknowledge and thank one of our senior residents, Jillian Duffy, whose academic interests and curricular project this year inspired this talk. So to start, I want everyone to picture themselves at the beginning of a shift. You've put away your bag, you have your PPE on, you're getting settled in to take sign out. Then one of your colleagues comes up to you and says, "Hey, remember that patient from yesterday?" This is the phrase that strikes fear into the heart of everyone in medicine. It causes a flurry of emotions: fear, worry, dread, but also shame. That sense of, oh no, I messed up and now everyone knows, and desire to go hide in the corner. But why? Why do we have this reaction to such a benign phrase? And when in our training did this start? As a medical student, when a resident would say this to me, I was so excited to get an interesting update on a patient. But now when I hear that phrase, no matter the tone it's presented in, I dread what comes next. Shame is a universal human emotion, but we in medicine, and especially in EM, are uniquely prone to shame reactions and the detrimental effects. Our learners are especially high risk for prolonged shame reactions and the resulting burnout and disengagement from learning. It is vital that we help our learners develop shame resilience in order to optimize their learning and cope with the challenges that come with a career in EM. So today, we want to talk about shame. Specifically, we want to differentiate between the emotions of shame and guilt and describe why this distinction really matters. We will describe how learners experience shame and how this affects their wellness and education. And finally, we want to leave you with specific strategies for pushing learners while also building shame resilience. Okay, so we're going to shame. We want to give some background on general emotions and learning. In the past, human thinking was conceptualized as a primary cognitive activity, relatively free of emotion. However, in the last 15 years or so, education scholars have begun to recognize the importance of emotions on learning and now place similar emphasis on the construct when it comes with learning as they do with more cognitive ones, such as attention and memory. There are many theories around emotions and learning, but a predominant theory is the control value theory. In very simplistic terms, emotions can be characterized by where they fall on two continuums. First, they can be described by their valence, aka how positive or negative they are, or how pleasant or unpleasant. Additionally, emotions can be stratified by the degree of psychological arousal, aka how activating or deactivating they are. Along these descriptions, most of the basic emotions can be mapped out along the dimensions, where the enjoyment of preparing for an interesting task would be a positive, activating emotion, whereas the relief after successful completion of a procedure would be a positive, deactivating emotion. Likewise, the anxiety associated with the first time major procedure would be a negative but activating emotion, whereas the boredom felt during an understanding lecture would be a negative, deactivating emotion. The connections between learning and emotion are complex, but it is most likely that emotions influence cognition and motivation, which then in turn affect learning and performance. The relative effect of those emotions on cognition and motivation, though, is based on the valence and psychological arousal. And these emotions have an effect in various ways. First, emotions affect our perception of information, both how we interpret it and how we act on it. To illustrate this, I want to walk you through two quick examples. First, emotion can affect cognition by altering how we process information. A large amount of research has shown that when in a positive mood, people are more likely to see the big picture by focusing on more generalizable components. However, when in a bad mood, people are more likely to focus on specific details. In one study, researchers had subjects watch a movie designed to evoke either strong positive or strong negative emotion. The subjects were then asked to decide which of the two items on the screen, A or B in the bottom here, more closely resemble the target item at the top of the screen. Those experiencing a positive emotions were more likely to select A, matching based on the global features, the overall triangular shape. Whereas those experiencing negative emotions were more likely to select B, looking at the local components, i.e., that the component shapes were all circles. Essentially, people in a good mood can see the forest for the trees. Our emotions also affect our cognitive flexibility, which affects our ability to creatively problem solve. In another study, researchers asked subjects to write about either happy or sad life events. The subjects were then asked to do problem solving tasks. We had to form a 4-letter word from a string of seemingly meaningless letters without rearranging any letters. So, for example, from this string of letters, subjects would form the word frog by picking out every other letter. This is then repeated multiple times with other strings of letters, and for all of them, the word could be formed using this every other strategy. But then, after people got used to this problem solving strategy, the researchers changed the pattern. Subjects were then given a string of letters that required a different problem solving strategy. The people who had been primed with negative emotions continued to attempt to use the every other pattern to problem solve, resulting in nonsense words. They also continued using this strategy until they got external feedback that this strategy was inadequate and should attempt another strategy. However, learners in a positive mood were much more likely to abandon the established strategy on their own, and without prompting, they recognized the more obvious strategy. This, and other similar experiments, demonstrate that positive emotions facilitate creativity, cognitive flexibility, and openness to new information, whereas negative emotions may hinder this. These two examples are of how emotions can affect cognition, but also has greater effects on learning. Emotions have a larger effect on memory beyond the fact that memories associated with strong emotional reactions are easier to recall. Strong emotions, especially negative emotions, negatively impact a learner's cognitive load by consuming working memory when resources are focused on the object of the emotion rather than the task at hand. And they also have a large effect on motivation, where positive emotions are more likely to stimulate intrinsic motivation, and negative emotions are more likely to stimulate extrinsic motivation. So we know emotions can have a profound effect on learning, and there's a large evidence suggests that on a whole, negative emotions can adversely affect learning performance. But it's not black and white, and the answer isn't just to shield our learners from ever feeling bad in the name of wellness. First, because there are some circumstances where negative emotions could be beneficial, depending on the nature of the task and the skills required for success. For example, there are times when focusing on the details, i.e., the trees instead of the forest, may be beneficial, say when a procedure is going wrong. But also, we cannot avoid negative emotions, especially in medicine and medical education. Our learners are going to make mistakes. They're going to have failures. They're going to have bad patient outcomes. And we don't want to teach them maladaptive or avoidant behavior or teach them to avoid difficult situations going forward. Also, as an aside, I personally would never want a doctor who didn't feel bad about their mistakes. So then, how do we help our learners deal with the inevitable negative emotions that come with training, but in the most productive and least harmful way? We want to focus on two specific negative emotions: shame and guilt. These are a subset of emotions called self conscious emotions. Self conscious emotions are different than basic emotions that we talked about so far, such as anger or joy, in that they are based on an appraisal of the self and perception of how others see us. Self conscious emotions occur when, after a triggering event, a person reflects on their current self perception, how do I feel right now, and compares that to their ideal self. How do I want to view myself now and in the future? If those feelings are congruent, I just crushed that procedure and I want to be known as the resident who can always get vascular access, then that feeling is pride, a positive self conscious emotion. However, if how you're feeling in the moment is different than your idealized self, you experience guilt or shame. Because that distance, the distance between who I see myself as now and who I want to see myself as, that feels bad. So basic emotions are automatic reactions that we have to events. They happen in direct response to a trigger and do not involve cognitive processing. Whereas self-conscious emotions, shame, guilt, pride, require that extra step of self-reflection and evaluation. Both shame and guilt are negative self-conscious emotions that occur when we feel bad about ourselves. These are both negative emotions and come with the same complex and likely adverse effect on learning that we mentioned earlier. But the importance difference between the two, though, lies in our attribution of the locus of control. That is, what is within our control and changeable versus what is not. With shame, the person attributes the negative feelings of something stable about the global self or their competence. The negative thing happened because I fundamentally am a bad person. I am stupid. I'm a fraud. I always have been. I always will be. On the other hand, guilt is when the person attributes a negative outcome to something changeable and variable about their behaviors and actions. It is the I did something bad rather than I am bad. To illustrate this, say a resident who is upset after placing a central line because it caused a pneumothorax. If they feel that this complication was something external than themselves, say a resident bumped into them during it, they are not going to have that self reflection and they're going to attribute it to something outside of themselves. And they're going to feel a basic emotion, frustration, anger. But if they feel it's complication because something they did, they self reflect and they might feel guilt or shame. Shame would be the reaction of, I'm bad at procedures, I always have been, and everyone's going to know that I messed up again. And if there's another line this shift, I don't want to do it. I'm going to give it to a junior learner. Instead, if they have a guilt reaction, the response might be, I feel bad. I'm embarrassed. I made a mistake. I could have done better. I didn't focus on my needle tip and I rushed the procedure. So the next one, I'm going to take my time, slow down, and maybe this will go better. It's not just that these shame and guilt are negative emotions. As you can tell from what I just said, because it's difference of locus of control, guilt is an activating emotion and shame is a deactivating emotion. Shame does not allow us for the possibility of change because that feeling that the person at their core is flawed and always will be. Guilt, however, is a negative feeling about changeable actions and allows the opportunity to improve and provides some motivation to get there. And those of you in the audience making the connection already, this is very analogous and likely plays a large role in the idea of growth mindset. So, because our learners are going to make mistakes or have disappointments, it's a normal part of our career and our job, we as educators can help our learners by helping them move from a shame reaction to the more productive feeling of guilt.
We totally acknowledge that this doesn't mean that guilt feels good. And it doesn't mean that we advocate using guilt as a teaching strategy. But we can see the utility in both making a distinction and fostering that distinction amongst our learners. They're going to have negative experiences and feelings. Like Laura discussed, it's impossible not to in medicine. Our goal is to help them process them in the most productive and least traumatic way. A learner who feels like a bad person may give up and lose the desire to improve, while a learner who can separate a mistake from their identity will find motivation to improve. This is a critical difference that we want to foster. But to dive a bit deeper, what is the significance of a learner being in a shame state? Is there really even a reason to confront it? Well, for one thing, there is an abundance of research that links unnavigated shame to bad outcomes. We know from psychology research that in the general population, higher rates of shame are associated with higher rates of depression, suicide, isolation, moral injury, and burnout. Many of these negative effects are not new to those of us in medicine. The quote above from a medical student in New York City highlights what many of us, or those we have trained with, have experienced during their own medical education. I'll give you a moment to read. I'm sure this triggers some memories of your own, but this isn't just anecdotal. There's an abundance of research on physician stress, depression, and burnout, especially when it comes to residency education and training. This has been demonstrated broadly across the majority of specialties. So just to briefly summarize a few, in a longitudinal study by Campbell et al., they found that 78% of medicine residents experienced at least one episode of burnout during training. And for those who did, burnout tended to persist through residency. Another survey of general surgery residents reported that 28% experienced weekly feelings of emotional exhaustion, and 32% reported a very poor or not great personal and professional balance. Lastly, the intern health study found that approximately 20% of the internal medicine residents they followed reported a major depressive episode during their intern year alone. It's been clear for some time that these are detrimental issues that impact the entirety of our medical community. Much of this initially was thought to be due to the more quantitative factors, such as hours on duty or workload. But maybe we need to reframe how we're thinking about this and look more at how shame experiences and other psychological factors may have an effect. One recent study that attempted to explore this relationship was performed by Shapiro et al. In 2017. They surveyed 217 OMFS residents utilizing a validated shame questionnaire and the Matchbox Burnout Index to identify effective shame experiences. Just for some background, shame events are negative experiences or instances which elicit the emotional response of feeling personal defect or failure. And we'll touch on specific examples later. In this instance, shame events were defined as being banished from the OR, being yelled at, being called names, including being called stupid, or being threatened. As illustrated by the graph above, it was found that residents experiencing higher number of shame events, greater than 5 in this case, that's seen in blue on the graph, were also more likely to report many of these negative effects discussed. 77% reported loss of confidence in their abilities, 58% reported depression, 55% isolation, and half poor job performance. Those who reported experiencing 1 to 5 shame events, seen in orange, still reported these negative effects, but at significantly lower percentages. Overall, it was found that these residents were significantly more likely to experience moderate to severe burnout and severe depersonalization. This demonstrates how much impact shame experiences can have on physician wellness. But why does it appear that shame itself is so prevalent within the field of medicine? Sorry. This is likely because there's many additional sources of shame in medicine that don't always come into play in the general population. Many factors we'll touch on, but for one thing, we as physicians tend to conflate our personal and professional identities. We do this on purpose. It's built into our training. We want doctors who are driven to really take ownership of and seek benefit for their patients. However, in doing so, the lines between work life and professional life become blurred. Additionally, just by the structure and intensity of medical education training today, our learners are put at an increased risk of experiencing social isolation and impaired sense of belonging, diminished psychological and physician wellness, fatigue with reduced self-regulation and risk of unprofessional behaviors, and impaired empathy. So the real question becomes, how do we potentially mitigate these shame events? But to begin to understand this, we really have to know where these events occur. In one study by Bynum et al. That explored how residents experience shame, they noted that events triggering shame reactions occurred in 3 major areas: patient care, learning, and personal goals. This work was done specifically in IM residents, though as you'll see, the areas are applicable across residency specialties. When it came to patient care, triggering events included perceived medical errors causing significant harm or even death, and ruminating on these errors, inability to relieve patient suffering, impaired or absent empathy, or conversely, even crying in front of a patient. Those that elicited shame during learning included enduring harsh remediation or negative feedback, having an M&M, frequently perceiving underperformance or inadequate and deficient knowledge, inability to function independently, being wrong on rounds or when being pimped, or even just having low test scores. Finally, triggering events related to personal goals included not being selected chief resident, perceived failure as a partner or a parent, academic rejection, whether from residency or fellowship positions or from a submitted journal article or presentation. It was found that most often the most intense shame reactions were triggered by one singular significant event. However, these could also be elicited by the accumulation of smaller, repeated, and related events. Within emergency medicine itself, one could come up with countless other potential causes for shame reactions, like a bad code, a missed procedure, hearing your care being critiqued by inpatient services, or having a bad interaction with consultants, or even leaving a messy board or procedure for the next team coming on. All in all, these events are common in medicine, And most of us could list examples of shame-inducing experiences, even just from our last shift. Importantly, some individuals may be more prone to experience shame rather than guilt. And there's some systems and conditions that may increase this probability. In the same work, Bynum found several factors that contribute to the likelihood that a learner would experience a shame reaction itself. First is comparison to others. This is especially common early in training, as learners are trying to gauge where they stand and frequently compare their knowledge base and abilities to their peers. Similarly, specifically for us in EM, you're frequently working in collaborative settings along with your peers, and it becomes challenging not to notice how others are performing in relation to you. Those of us that choose to go into medicine are by nature overachievers, and a failure to achieve a high level of execution can be shame-inducing, as we take these as personal failures. We constantly focus on our performance, which can be detrimental. Additionally, this is a field in which this is not only evaluated constantly, but performance occurs in very high stakes and high stress situations. As learners transition to residency and clinical practice, there becomes a greater emphasis on subjective standards of evaluation, rather than the clear and often rigorous objective standards they've been used to for much of their time as adult learners. Many learners struggle with this lack of clarity. Feedback's infrequent and comes from a range of seniors and attendings with varying practice styles and expectations. You may be told a specific perspective on the work of a chief complaint one day, and the next be instructed to do things completely differently for the same complaint by a different provider. This can make it more difficult to have an accurate self-assessment of performance and opens the door for self-doubt. Perfectionism is an unattainable standard for even the most seasoned physician, yet many medical learners inherently feel they must have perfect performance, knowledge base, etc. When they fail to meet these standards they've set for themselves, it leads to feeling flawed or deficient as a physician. Fear of judgment, which contributes to a learner shame reaction, comes from many sources: seniors and attendings, peers, consultants, even patients. This can occur not only in more formal venues such as M&M or conferences, but also on shift with supervisors, or simply having to explain a difficult concept or a failure to a patient and their families. There's an anxiety that these judgments may have an impact on the learner's overall reputation going forward through their career. Learners have a tendency to blame themselves or assess their performance too harshly, even if there is situational evidence that suggests other factors may have a large influence. To put it briefly, they have a skewed frame of reference. These analyses that are inconsistent with contextual realities lead to often unfounded feelings of shame and self-blame. Lastly, as we'll discuss, we as supervisors play a critical role in a learner shame reaction. Our teaching and feedback methods, response to learner errors, acknowledgement, or really lack thereof, or a learner's emotional state, among other things, can serve to either mitigate or amplify the shame reaction a learner is already experiencing. Transitions themselves are a crucible for this entire list and are compounded by the inherent sense of impaired belonging and imposter syndrome that comes with any new experience. So we can see why transitions appear to be a particularly fraught time for shame experiences. It's inherently a time of upheaval and self-reflection. Medical learners may experience feelings of shame during these periods due to the perception that they're performing at a lower level than everyone else, that they don't belong, that they might be judged by others. This risk might be heightened further if they overly rely on quantitative metrics of performance to validate their self-worth, or they hold on to perfectionist standards of performance that are unachievable and unrealistic. Key transitions within the journey of medical education include the beginning of medical school, the transition into clinical practice as a medical student, all of intern year, but particularly early in the year, and soon after assuming new responsibilities as a senior resident. These are universal milestones that all medical learners must experience and progress through. And we as educators must have a heightened awareness of the learner's mental well-being and ability to cope during these times to help mitigate these shame experiences. The psychology literature has shown a link between shame and suicidality, and unrecognized shame during transition periods may help explain Yangmore et al.'s recent finding of a greater number of recent suicides in early intern year than during other times of training. So now we know that shame is an unavoidable negative emotion, leads to detrimental long-term mental health effects, and we know that it's deactivating. We also know that we have just a short few years to teach our residents the vast amount of medicine involved in our specialty, the life-saving procedures they'll need to succeed, and the relational skills that foster effective team-based care. We also want to foster the motivation and ownership to be a lifelong learner. We can feel very secure that trainees will make mistakes along the way, and they'll be prone to and be at risk for shame reactions. Knowing this, it's vital that we as educators understand how we can help our learners build shame resilience. Shame resilience itself is defined as the ability to proactively confront shame in a way that enhances one's beliefs about oneself, increases one's sense of power and control, and restores one's sense of interpersonal connection and social standing. We can't stop bad things from happening. This is medicine. Bad things will happen regardless of whether our mistakes caused them or not. The goal is to teach people how to move through these moments rather than descending into a shame spiral.
The concept of shame resilience is borrowed from research in the general population, including work done by Dr. Brené Brown. You may lump Dr. Brown in with pop psychology self-help gurus, but her credentials are rock solid. She is a well-respected social scientist and research professor with multiple peer-reviewed research articles on shame and vulnerability. Think more Dr. Fauci rather than Dr. Oz. Dr. Brown has identified 4 basic components of shame resilience. First, we must recognize shame and understand its triggers. Shame is a feeling. We feel feelings in our bodies, but they can be hard to pinpoint and instead feel like an all-over sensation. Often, it is even harder to name a feeling than it is to locate the sensation. Sometimes it's easier to name an emotion in others than it is in ourselves. Simply practicing emotion recognition is helpful. Next, we practice critical awareness of the influences leading to shame. We do this by allowing space for the feeling, looking for the trigger, and putting some perspective around the experience. A simplified example of this might sound like, I notice that sick feeling in my stomach and crawling up my spine. It feels like it might be shame. I think it is related to dropping a lung on the central line I placed today. This doesn't feel good at all. I wonder if this has happened to someone else before me. I'm going to remain open to learning what I can to do better next time. Step 3, reaching out to others, is arguably the scariest part, especially early in the journey of shame resilience. It is the nature of shame to make us feel alone and unworthy. Making ourselves vulnerable to someone else can feel like an insurmountable obstacle. Ironically, though, it is in reaching out to others that we reclaim our sense of self and really begin to understand that the mistake and our identities are separate, not one and the same. In reaching out, we strip shame of its ability to isolate us, and we can get help in putting the experience in perspective. Finally, discussing shame. To quote Dr. Brown, if we cultivate enough awareness about shame to name it and to speak it, we've basically cut it off at the knees. That is, by acknowledging the universality of the shame experience and lifting the taboo of talking about shame, we completely destroy its power. This 4-part model has been applied successfully across various fields of study, including music education, workplace dynamics, and leadership training. It's time to consciously bring it to medical education. The opportunity to impact rates of burnout, depression, and isolation to literally save a life insists that we try. A person who never made a mistake never tried anything new, Albert Einstein. As learners, making a mistake often makes us feel isolated and unworthy. We feel that others know more and are better than we are. The reality is, learning and mistakes go hand in hand. Bynum et al. Looked at shame resilience traits in medical learners and found, similar to the shame resilience theory, that number 1, confronting perfectionism can build shame resilience. Number 2, building the skill of transitioning from shame to a guilt response can facilitate recovery from shame. And number 3, reaching out to others during a shame reaction is critical. And peer-to-peer support is an effective way for students to build shame-resilient environments within their sphere of influence. We can foster an improved learning environment by bringing awareness of the role that shame can play in training, helping our learners mitigate shame experiences, and sharing tools with our learners to build coping mechanisms. So how can we develop this culture in our learning environments? We can take the focus off of metrics and put it on process, emphasizing grit by rewarding the effort of staying with a difficult endeavor, rather than only recognizing a binary of success or failure may engender shame resilience. The goal of mastery remains the same. We simply recognize that mistakes are part of the learning process, and we provide support as the learning unfolds. By continually reinforcing that mistakes simply signal, I have more to learn, rather than I am a bad person, our trainees can become activated and accountable for their own improvement. We can also reinforce the tenets of shame resilience theory. We can acknowledge the presence of shame and guilt and point out potential triggers for our learners. We can work on recognizing when our residents are struggling or have had a difficult interaction, providing support to explore their emotions and find constructive responses. We need to be aware of how shame may manifest itself in our learners, and that not everyone responds in the same ways. A learner who becomes outwardly embarrassed or distressed is easy to recognize, but unexpected responses, such as unprofessional or isolating behaviors, may be more difficult manifestations of shame. If we miss these cues and just attribute them to personality traits of the learner, we may lose the opportunity to guide more constructive responses. We can be especially attuned to the times and places where shame shows up, particularly major training transitions. Check in on your interns. Ask them not only how are they doing, but how are they feeling? Second, we need to have a critical awareness of how and when our own behaviors might induce a shame response. Our intentions don't always align with the recipient's perceptions. In a longitudinal study, Seabrook et al. Followed medical students and doctors at a British medical school. They explored the use of intimidation tactics and humiliation. They found that doctors justified these tactics by reasoning that it helped or motivated students to learn and prepared them for life as a physician. However, students felt that these tactics made them lose self-confidence, embarrassed them, and made them more likely to keep quiet or withdraw from learning opportunities. They found that many of the physicians were unaware of the effects they were having on students. Humiliation can turn into internalized shame. The learner begins to believe the implied message of unworthiness. If students have the perspective to understand that this treatment is unfounded, inaccurate, or over the top, they might avoid this, but all too often they don't, and it turns into a shame spiral. The more episodes a learner experiences, the harder this becomes to avoid. Consider the Socratic method versus pimping. Asking someone a question is a valid educational technique, but using embarrassment actually alters our ability to use the information. Recalling the concept of positive and negative emotions, the negative emotions of pimping make the experience memorable, but renders the learner less likely to make broader intellectual connections and transfer the learned information to other clinical scenarios. Also, it stimulates external motivation rather than internal motivation. Last, we can give effective feedback. It's key that feedback address actions and behaviors, changeable things, rather than the individual itself. Studies have shown that personal critiques lead to decreased self-efficacy, increased avoidance, lowering of goals, and increased rates of quitting, paralleling the shame response. Instead, by focusing on actions, hey, I saw you anticipated the swap in CPR providers, or engaging the CNA in that patient's care was a smart use of resources. We engage the learner in looking for more opportunities for positive behaviors. Other positive feedback methods include normalization of mistakes, avoiding overly harsh reprimands, accepting partial responsibility for errors, and using neutral, non-judgmental language. Occasionally revealing one's own learning curve can normalize failures or feelings of shame. and can help learners put their experience in perspective or find constructive ways to respond. By this time, I hope we've convinced you that our emotions play an important role in learning, that shame is a particularly deactivating emotion, and that taking a conscious approach to shame resilience education is supported by the literature. But what might a program look like that fosters shame resilience? How can we build communities that shift the mistake narrative from a presumption of unworthiness to evidence of an engaged, gritty learner? We did a needs assessment of our existing group of residents toward the end of the last academic year. We asked them to describe experiences that have been helpful to them in building their own resilience as they have gone through training. Here are some quotes. I'll give you a minute to read them. As you can see, many of the key points we have discussed were brought up by our residents as well. We built a curriculum for the incoming interns using this needs assessment and based on the shame resilience theory. We built on the inherent understanding of a group of high achievers by normalizing and discussing the physiology of the stress response. We reinforced that feelings are real body processes with measurable signs and symptoms that affect us. And we started by offering in the moment life-preserving tools that they could use without anyone even knowing what they were doing. Some examples include reframing the emotional response as knowledge we can use, taking a deep breath and holding it, square breathing, asking for help, finding something that interrupts your spiral by reconnecting with the world around you, by touching something, stretching, taking a drink, clenching and unclenching your jaw, setting respectful boundaries, or something called 5, 4, 3, 2, 1, where you return to your 5 senses to interrupt your emotional response. This might look like tell yourself 5 things that you can see, 4 things that you can hear, 3 things that you can taste, whatever it is. Don't we love graphs in medicine? If we can present the physiology of emotion in a graph, then it must be science. Really though, for most of the day, we exist in our body's window of tolerance to outside stressors, between the green lines. When the stimuli of the day exceed our window of tolerance, our body physiologically prepares to fight, run away, or freeze. Heart rate, breathing, digestion, all are affected. Our thinking brain starts to go offline and leave our bodies to respond by instinct to escape the threat. Usually, when the threat is gone, our body comes back to a state of stability and recuperates. However, when one's stress response is stuck on for long periods of time, it becomes dysregulated, going from hyper to hypoarousal and not spending much time in the window of tolerance. We oscillate between being hyperalert, agitated, afraid, and defensive, with withdrawal, depression, and zoning out. Many of us are overwhelmed, dazed, and numb. It's important to recognize that this is an instinctual physiologic response. It's not a reflection of one's strength, character, or intelligence. The tools we share are proven to help with the physiologic regulation in the moment. They help bring us from hyper or hypo-aroused back into the window of tolerance. By recognizing our emotional state and practicing these techniques, we adapt to new experiences. We are ultimately learning to navigate through discomfort and fear. Again, we reframe the emotional response as knowledge we can use to activate adaptive tools. If you've ever been in sports, theater, music, or any number of other pursuits and have a favorite technique to use before you play or perform, then you've already had experience with these tools, likely without ever knowing that you were doing it. In addition to teaching skills that can be employed in the moment, we have 3 one-hour sessions in which we mix this learning with self and group reflection. We make space for them to reflect on their own experiences as they're moving through intern year. We discuss the individual factors that are important to shame resilience, like simply recognizing when you are feeling stress, fear, shame, anxiety, or fatigue. We build in the moment skills like square breathing and setting boundaries. We discuss recognizing when someone is using shame in a misguided attempt to teach them something. We normalize the first time experience and encourage help seeking. We discuss cognitive skills like using frame of reference to shift our perspective. We encourage them to develop systems that work for their peer group that have nothing to do with us, their teachers. Hashtag #FailShare has become a touchstone within the residency, and both in a group text and in the course of conversation. This vulnerability allows them to see each other's humanity and recognize that they are not the only person facing challenges. In addition to the practical skills, we teach them shame resilience theory and the science that goes into it, again, normalizing the effective technique of reaching out to others, professionals, or our faculty when they struggle. We reveal our own tough moments to them so they know that even their teachers can and have had shame spirals of their own. This is just the beginning of the exploration of shame in medicine. We've touched on some of these, but shame likely plays an underlying role in all of medical education, including psychological safety, professional identity formation, the learning environment, feedback, wellness and burnout, and the growth mindset. Because shame is a feeling inside of us, it touches all aspects of our professional development. It's possible to carry it with us into every setting or experience. It is especially prevalent in medicine, given the high stakes decision-making and culture of striving that propelled us through the medical school admissions process. Its propensity to lead to isolation, depression, and a sense of unworthiness make it a sinister and sneaky emotion that can take years to recognize. By addressing it directly, we have the opportunity to impact something fundamental to all aspects of our trainees' professional life. The tools to combat these feelings are available and do not require any fancy gadgets. As Dr. Welsh showed us, using cognitive science literature, our emotions can actually help us learn more efficiently and flexibly. As Dr. Clark discussed, negative emotions, shame in particular, can have long-term repercussions that affect our entire medical careers. By teaching shame science, identifying and building skills that help us transition from shame spirals to more adaptive responses, and providing safety and space to experience honest emotions and practice resilience skills, we can teach trainees early on what has taken many of us decades to understand. Resilience training can't take away anyone's pain or processing. This is life and hard things will happen. We have stepped into a career filled with hard things. As educators, what we can do is help our learners to adapt to events outside their comfort zone in a supportive way. So in the future, when they hear the phrase, "Remember that patient," hopefully their reaction will be, "How can I get better?" instead of "What did I do wrong?" Thank you so much for your attention today. This is our contact information, and we encourage you to reach out with any questions you might have. We'd be delighted to share the details of our intern workshop with you and work together to prove the benefit of this addition to the education curriculum. And I think that we have a few minutes if people would like to ask questions right now. And I can also look at the chat.
There are a couple in the chat. I don't know if you guys can see them.
I can pull them up now. First question, how could you reach out when it was a person outside yourself who named your failure and shamed you? Or do you call that humiliation, and are they the same? What about the role of shame, shaming, guilt, and humiliation in physician suicide? These are all really great questions, Dr. Totten. I think I would, when someone brings it to me, they're using shame, but I guess I would probably call that humiliation. Avery and Laura, I encourage you to answer as well. But I think that it's very clear that the literature definitely supports that, that shame is significant in the role of physician suicide.
Yeah, I would say to the suicide point, in the general population, we know that shame is associated with increased rates of death by suicide and suicidal thoughts. And that we know in the medical literature that there are increased rates of shame around transitions, especially worse around intern year. It has been proposed as a reason that we do see the highest rates of physician death by suicide during intern year. So it hasn't actually been officially explored, but it's been proposed as a likely linkage. And I would say for the idea of if someone humiliates you, that's hard to, you can't control. And as a learner, someone doesn't always intend to humiliate you, but you feel humiliated. Hence that whole remember that patient. That's a very shame-inducing phrase that's very benign, even without the intent of humiliation. But some also do intend to humiliate. We've all had those attendings, remember as medical students, or even colleagues as attendings who may humiliate us at M&M or on rounds. And the idea is, and when we teach our residents, is that
surgical M&M is traditionally very humiliating.
yes, that in the research has been found to be a huge stimulator of shame. But teaching the residents of when to recognize someone is doing that to them and recognize the feeling and try to put up barriers and not let them, but then also share with their colleagues of like, I'm feeling this way. Are you feeling this way? Have you ever felt this way? And normalizing that response.
And I think sometimes too, depending on the setting, in terms of reaching out, you can tell sometimes when maybe it was an unintended shaming experience. The person didn't realize they were shaming you with what they were saying, similar to the remember that patient aspect. And I think in those instances, sometimes it's okay to reach out to that person themselves too, and kind of let them know how that comes across versus yes, in M&M and more structured things where that's kind of inherently the case. I think when we talk about reaching out, it's to your colleagues, it's to your peers, it's to people that can relate to those experiences too, because obviously that's not really the right avenue for kind of discussing it at that point. But finding those resources that you feel like you can open up to and kind of share how you were feeling.
I think in terms of M&M in particular, did come up. One of the things to talk about is normalizing and modeling that as attendings, we can model more the guilt or response rather than a shame response to mistake by speaking up and saying, this is my patient, especially if it's an anonymous case. This is what I did. Here's how I'm learning from it. Here's how I feel. And here's how I'm going to do this to make it to move forward and not have this happen again, and model that mindset rather than the hiding in the background, not acknowledging that was your case.
I congratulate this group for this presentation. I think it's an incredible presentation, and I think it has the potential, if adapted, to really kind of really improve residency and learning. I love the idea of switching to a growth mindset and how this helps kind of setting the expectations from the very beginning. Listen, this is what shame is. We all feel it. You're not the only one. If you feel it, we encourage you to talk about it, and then by modeling it. So I think this is really, I love this curriculum.
Thank you. There's another comment. We're getting a 2-minute warning, but I just want to address this comment in the chat. Mindfulness practice or mindfulness-based stress reduction, perhaps these can be used to learn to recognize and acknowledge shame. I completely agree with you. I think a lot of this is about mindfulness, but I think what actually makes a difference for me when I think about mindfulness, I mean, now I know mindfulness is a totally valid tool, but I think when people are coming to this without really knowing or wrestling with these ideas in the past, I feel like an important part of the curriculum is actually identifying and naming the physiology that's going on, so that it's not just, you know, you're going to feel better with mindfulness. It's also a recognition of your body is actually doing things, and we have techniques. One of them is called mindfulness that you can use to affect your body's system in the moment, that there's actual science that goes into this. I completely agree that mindfulness is an important skill.
And to the second point in the chat, that it is very hard to do on a busy shift, hard to take that moment. And we do tell our interns that, especially when they feel they see more patients, do more, and their senior residents are pushing them to do more. You are not wrong to take a minute, go into a crowded, like an empty hallway, and do this kind of in the moment mindfulness or deep breathing to get yourself in check, because we know that the shame spiral or the negative emotions will affect the rest of your shift. It is worth taking those 10 seconds to the rest of your care over the course of the shift will be better.
All right. We're told it's time.
Excellent job.
Thank you all for being here today. Really appreciate it.
Have a great day, everyone.
Thank you.